chemoimmunotherapy to use, we've since had an update in JCO, looking at the multi-center study for the risk-adapted treatment with DAR-EPOCH. So I think we know what the latest this multi-center trial showed, but we'll skip through this evaluation and treatment of Burkitt's in the modern era. We will look at the expected age in this cohort. It's similar, 17 to 88 years of age. ECOG performance status is pretty good and standard, but the rest of the disease characteristics are what one would expect in Burkitt's lymphoma. And these are the common regimens which we have been using throughout the world. And different experiences have been observed. So here is the response and the TRM. We can appreciate that the three overall survival and the PFS within this group is around 72% and 65% PFS within that time. The TRM was seen, so the highest TRM was with hyper-CVAD and methotrexate regimen, followed by the DA-EPOCH-R, and then followed by the Codox-M-IRAC. There was no, interestingly, difference between the HIV positive and the negative group. This slide again looks at the other predictors for inferior outcome in the multivariate analysis, looking at the age over 40 and high LDH with a poor performance status do bad, which is what we know. But I think this is just consolidating our knowledge on these slides. Again, the effect of the risk factors on survival carrying on. This we know that the patients with zero risk factors will do better in terms of their progression-free and the overall survival. The regimens to choose, which regimen to choose, and as you can see here, that there's not much of a difference seen between the hyper-CVAD or the modified modified Codox-M-IRAC, which is the McGrath, or the DAR-EPOCH. So you can pick and choose any, but the difference was seen with rituximab addition, which improved the progression-free survival. And I think this just consolidates and echoes what the latest multi-center trial about the DA-EPOCH-R has actually come through in JCO. So the safety data is one would expect that the TRM was about 8 to 9% in patients with HIV, and the most common side effects were sepsis and GI bleed, which counted about 14%, and the TRM was highest in the hyper-CVAD and methotrexate arm. Patients who experienced disease progression, the 90% of those who had disease progression occurred within the first 12 months from diagnosis, and 4% after 2 years. So it's quite important that whatever hit you're going to give them has to be the hardest to see the best benefit. The other outcome from this was that about 4% of these cases had secondary malignancies, including MDS and AML, or 6 cases of Hodgkin's and other non-Hodgkin's lymphoma were noted with a median follow-up of 54 months. Just putting another slide very quickly, summarizing in this one slide to show that the outcomes for the newly diagnosed Burkitt's lymphoma and central nervous system involvement, the increased risk of CNS recurrence with DA-EPOCH was highest in this plot, as one can appreciate, and the cumulative incidence of CNS occurrence is up to 6% with this group, and the higher the risk factors here, the more the risk factors, the poorer the outcome.